Welcome to our video on nephrolithiasis. In this video, we'll be focusing on the risk factors, classifications, and the clinical features of nephrolithiasis. Here is our overview slide. Let's begin with the definition. Nephrolithiasis is divided into two words, nephro meaning renal, and lithiasis meaning stone or calculi. So basically, nephrolithiasis is the development of stones within the urinary tract. The obstruction and resulting signs and symptoms depend on the site of obstruction. Here's an image of the urinary tract. The calyx of the kidney is located right here. The uretropelvic junction is here, and kidney stones, particularly staghorn calculi, are very commonly found in this region. Intersection of the ureter and iliac vessels near the pelvic brim is another common site of obstruction, which is right here. And uretovesicle means ureter and bladder. Therefore, this is the site where the ureter ends and connects to the bladder, right here. In general, the formation of stones is dependent on factors affecting the concentration of certain stone-forming substances within the urine, as well as urine pH. So a low fluid intake is the most common and modifiable risk factor and can predispose a person to highly concentrated urine, leading to increased osmolality and precipitation of crystals. A family history of nephrolithiasis is another risk factor. And finally, there are some conditions known to precipitate stone formation, such as gout due to hyperuricemia, Crohn's disease due to hyperoxaluria, hyperparathyroidism due to hypercalciuria, and type 1 renal tubular acidosis due to increased urinary pH. Other risk factors include medications such as loop diuretics, which can cause hypercalciuria, male gender, which is thought to be related to a high protein and high salt diet, UTIs due to urease-producing bacteria, and finally, dietary factors such as low calcium and high oxalate intake, both of which lead to hyperoxaluria and calcium oxalate stones. All right, let's continue with the classification of stones. Here's a table which outlines the various types of stones. Calcium oxalate stones are the most common form, and they account for 80 to 85% of urinary stones. Calcium phosphate stones account for about 15% and are usually associated with hypercalciuria. Now, these percentages are here for mere knowledge, but they're likely not worth memorizing for your exam. Just remember which ones are the most common. An acidic urine pH, which is less than 7, promotes calcium oxalate stone formation, while a basic pH, greater than 7, induces calcium phosphate stones. The calcium oxalate stones are shaped as an octahedron, which looks like a square with an X in the center. The calcium phosphate stones are elongated, wedge-shaped, and tend to form rosettes. The radiograph opacity is increased for stones that contain calcium, meaning they can be easily seen on X-ray. Here is a microscopic image of the calcium oxalate stones. Notice the octahedron shape and a square with an X in the center. Here's an illustration of calcium phosphate stones. Notice the wedge-shaped elongated crystals. The next type of stone are magnesium ammonium phosphate stones, or struvite stones, which form the staghorn calculi and account for about 15% of stones. The radiograph opacity is increased, but not as radiodense as calcium stones. The microscopic appearance is rectangular prisms or coffin lids. These occur in patients with recurrent UTIs due to urease-producing organisms like Proteus, Klebsiella, Serratia, and Enterobacter. These stones form an alkaline urine, which means that the urinary pH is greater than 7. Urea-splitting bacteria convert urea to ammonia, thus producing the alkaline urine. The resultant ammonia combines with magnesium and phosphate to form struvite calculi, which may involve the entire renal collecting system. Here is a microscopic image of the magnesium ammonium phosphate stones. Take a look at the long rectangular-shaped crystals. This is a gross view of large struvite stones caused by the magnesium ammonium phosphate deposits. Uric acid stones account for 5% of stones, and these stones are radiolucent, which means that they cannot be seen on an abdominal radiograph. They require CT, ultrasound, or an IV pyelogram for detection. An IV pyelogram, also called an excretory urogram, is an X-ray exam that uses contrast to view the urinary tract. On microscopic exam, they're seen as yellow or red-brown diamond or rhombus-shaped stones. These are associated with hyperuricemia secondary to gout or to chemotherapeutic treatment. As the cancer cells die, they release high quantities of uric acid, resulting in uric acid-related stones. A persistently acidic urine, which is defined as a pH less than 5.5, promotes uric acid stone formation. Here's a microscopic view of the uric acid crystals. Notice that these are rhomboid-shaped. Here's a non-contrast CT image of the abdomen. We can see a hyperdense mass indicated by the arrow, likely representing a renal stone. Recall that non-contrast CT is the imaging of choice for renal stones, as it can detect radiolucent stones and would otherwise be missed by conventional chest radiography. Non-contrast CT also gives us detailed information about the size and location of the stone, which directly impacts treatment. And finally, cystine stones account for 1% of urinary stones. The radiograph opacity is typically increased. A risk factor for cystine stone formation is a decreased pH, usually less than 7, and urine supersaturation with cystine. This is typically seen in cystinuria, which is an autosomal recessive disease usually seen in children. On microscopic appearance, we should see flat yellow hexagon-shaped crystals. This is a microscopic image of cystine crystals. Notice the flat yellow hexagonal shape. All right, let's finish up by discussing the clinical features of nephrolithiasis. One of the most common presenting symptoms is renal colic. Renal colic can occur for a few reasons, such as the kidney stone passing into the ureter, as well as ureteral obstruction and spasms. Distal ureteral stones can cause pain that radiates to the groin or testicle in the male and labia majora in the female due to irritation of the ilioinguinal or genitofemoral nerves. The patient will describe the location of the pain as beginning in the flank and radiating anteriorly toward the groin following the path of the stone. Typically, the pain is described as having a sudden onset and rapidly becoming a severe pain. However, it may occur in waves and wax and wane at times due to the spasmodic contractions. On exam, the examiner may notice that the patient is unable to sit still and will writhe due to the pain. Other symptoms that are common include nausea, vomiting, and hematuria, which is found in over 90% of cases. And lastly, UTIs, which can manifest with symptoms like pain with urination, fever, or blood in the urine, but we'll discuss them further in another lecture. All right, let's wrap up with a question. A 14-year-old male is brought to the emergency department with sudden onset of left-sided abdominal pain and blood in his urine. The pain waxes and wanes in intensity and does not improve with rest or position changes. He has a lengthy history of similar pain episodes, but this is the first time he has noticed blood in his urine. Physical examination shows costovertebral angle tenderness on the left side. Microscopic examination of the urine sediment shows hexagon-shaped crystals. Further laboratory evaluation is most likely to detect which of the following abnormalities in this patient: A. Aminoaciduria, B. Hypercalciuria, C. Hyperoxaluria, D. Hyperuricosuriria, or E. Hypocitruria. All right, hopefully you notice that this patient has a history of recurrent nephrolithiasis, and being a 14-year-old patient, it raises suspicion for a genetic defect. Hexagonal-shaped crystals were also identified on the urine sediment, which indicates cystine stones are present. Given this patient's young age, the shape of the crystals seen in the urine sediment, and a history of recurrent nephrolithiasis, it's likely that this patient has cystinuria, which is an autosomal recessive disorder affecting a sodium-independent amino acid transporter found on the proximal renal tubular epithelial cells. This defect prevents basic amino acids like cysteine, ornithine, lysine, and arginine from being reabsorbed in the proximal renal tubules and leads to supersaturation of the urine with cysteine, resulting in the formation of cystine stones. So, with this in mind, the correct answer is A, aminoaciduria. The other answer choices are all risk factors for recurrent calcium stone formation. However, these abnormalities are not typically found in patients with cystinuria. So, B, C, D, and E are incorrect, and again, the correct answer is A, aminoaciduria. And that concludes this section.